All right, we're going to go ahead and get started, everybody. Everybody, welcome back. Um, can you guys hear me okay?
I can hear you.
Awesome. Okay, cool. Thank you. You guys were all very silent, obviously, because you're on mute, and I didn't see your faces, so I want to make sure. So, welcome back, everybody. Can you guys believe this is our last class for this semester? You're getting close to the end. This the vision is in sight. Um, so I got a couple things I want to go over real quick before we get started on the actual lecture today. One of those is that there's been a few of you that have reached out to me and have had a problem submitting your test corrections for exam one. Every time I go in on my end, everything looks good, and there's a lot of you that have already handed in your test corrections for exam one. So I looked through it all. I can't figure out why it's doing it. And there's several of you that reached out. I've tried to answer each of you. What I did do today is I went in and I added a second um, test correction one. And so if you go in there, for those of you that contacted me and couldn't submit, try to use the other one that I set up. So all of you may see that as an assignment. If you've handed in your test correction one, you don't have to resubmit it on the second link or anything like that. Because those assignments are essentially worth zero until we put in whatever test corrections you did, it won't affect anybody's grade to not do the second exam one test corrections assignment link. But those of you that haven't been able to do it, if you would try to give that one a try, I don't know why it's doing it, so that's why I decided to just do another one and see if that worked out. I think there's just some weird glitch going on that I don't understand. So please try that, and if it doesn't work, please let me know, and then we'll go with another option. I'll try to get some tech support or something because I can't figure out why. Does that sound okay? All right,
Sounds good.
cool. Thank you.
I just submitted mine. It worked.
You did, Jamie. You submitted yours this morning.
Yeah.
Okay.
As soon as you said it, I submitted it. It works.
Okay. Awesome. Okay. We'll just go with that then. Sorry for those of you that had trouble with that. I have no idea what's going on with Canvas. And it's funny because again, like half of you have been able to use it and then the other half won't can't. I have no idea. It's got to be just a glitch. So awesome. Thank you. I'm glad we figured out a workaround. Appreciate that. Um, the other thing that I wanted to mention quickly before we start, just to be on lookout for this. This will be for your summer semester. I'll be the main instructor for your comprehensive review class, which is essentially board's review, try to get you ready for the exam. And I wanted to just point out the book we'll be using. I've mentioned this book already. This is the Norman E. Bolus is the author on this, and it's a review of nuclear medicine technology. That book is the only additional book that you'll be adding for either of my classes. I'll also be teaching you the quality assurance class, both of those. So no additional books for quality assurance, and you'll need this review book for the comprehensive review. So I just want to throw that out there so that's kind of on your radar. Those things should be on your classes when you register for summer semester. They'll be there as well, but just wanted to bring that to your attention. Um, and then also with our summer class, the first time that we'll be meeting, and I'll go over this more and I'll kind of cover a syllabus and everything at that time, but May 15th will be the date that we'll doing our first Zoom class. And during that time, I believe that the class is actually just quality assurance because the boards doesn't have a separate, the boards review class is kind of just on campus, and you should have all received something from Shane on that. But that May 15th date, I'll go over some of the board's review stuff as well as quality assurance just to kind of give you syllabus and understanding for both of those classes all at once, and then we'll go from there. So just some FYI stuff. Okay. Okay. If there's any other questions, I can take those at this time, or otherwise we will get started. Okay, let me get my screen shared with you guys. All right, can you guys see the slides okay?
Yeah,
Great. I think that was a yes. You cut out a little bit, but thank you. I'm assuming that was a yes. And then everyone, if you just just a reminder to make sure that you're muted, and then obviously, like I've always been, if you have questions, just interrupt me, and we can go for that. And then again, this probably won't be as long as last class, but if we start to get close to going over, you need to get to Brandon's class, then obviously just go, no problem. Okay, it's kind of our normal way. Okay, so this is a section 2B that matches with your module, and so today. We're going to cover PET perfusion. We did SPEC perfusion last time, so we'll talk about PET today. That'll be kind of the first half of this. And then we're also going to cover viability using thallium and also using FDG. And then we're going to cover cardiac amyloidosis. There are some other scans that are done in nuclear cardiology that we see. I'm not going to cover the things that aren't on the boards. That's kind of how I've chosen it here. There are some other things, and if you run into any other types of exams in nuclear cardiology that we haven't covered, I am more than happy to talk to you about those. I try to stick to these because it's what they've included on the boards. In fact, the last time that they kind of re-looked at the boards, which was I think 2 years ago, cardiac amyloidosis was not on there. And now they've added it. So we included that on there. There's also a scan that we often do at our facility that checks for cardiac inflammation and sarcoidosis. You may see those. I won't cover those here just simply because they're not on the boards yet. And I just want to try to keep you focused on what's on the boards. Okay. All right. So start out, and this is similar to the last time I kind of covered the type of nuclides that we use. So in PET perfusion, the main one I'm going to cover is rubidium-82. Now, there are some nuclides coming up in the PET world for cardiac that are starting to be used. They even have an FDG unit that are a type of a radioactive tracer that's coming up that they're using for PET. And so that's kind of cool. So there's stuff up and coming, but rubidium is far and wide the main one you're going to see as of right now. So that's what we'll cover. So rubidium is produced in a strontium-82 generator. So this is very similar to what you guys are used to with tech and being produced on a generator. So rubidium is produced from a strontium generator. Now the difference obviously is that strontium and rubidium are both decaying with an annihilation reaction of 102 MeV. So you have a 511 keV. Now we have to have those two 511 photons going in opposite directions to make PET work. Kind of think back to when we did our PET scan section last semester, right? We have the positron emission tomography, which is the two 511 photons traveling in opposite directions. We create a line of response in our camera, and that's how it works. So again, with anything PET-wise, you're always going to have a 511 keV. It's always going to be working that way because that's how PET works. One thing to pay attention to here, and this will come into play when we're talking about the rest of the stuff, is that it has a 75-second half-life. So this is very fast, out of the patient really quick, and happens really quick. So that kind of determines how we can stress the patient and what we can do, and we'll get into that. This is a potassium analog, so it has a similar chemical structure to potassium, and as such, it's able to cross the cell membrane with active transport through sodium and potassium pumps. Okay, so this is very similar to thallium in how it works. There's rapid distribution in the myocardium. Again, remember proportional blood flow. We talked about why that's important because when we do perfusion studies in nuclear cardiology, that's literally what we're doing is we're looking at blood flow. We want to be able to quantify blood flow, where there's blood flow, where there's reduction in blood flow. So again, very, very important that they're able to do that. It's got a 60% first pass efficiency. It does not redistribute like we talked about with thallium. Once it's in there, it stays. Again, it's not in there very long because of the 75-second half-life, but it stays in there. The other thing you'll notice on here is patient dose, 2 to 4 millisieverts. When we talked about SPEC last time, we talked about upwards of 10 millisieverts or more. And so this is a huge reduction compared to SPEC. So not only is it better because we get a better images with PET, but we also get a reduction in the average dose of a patient. Now, if you're thinking about oncology FDG, that might be a little different, right? Because in oncology, you're using something that's 110-minute half-life with FDG. And so we're thinking a little bit more about patient dose. There's a little bit more patient dose there, stays in the system longer, right? With this, the patient dose goes down a lot, not because it's a nuclide with a low KEV, it's really high. But again, it's not there very long. The other caveat that's kind of cool with rubidium is that your dose gets reduced as well as a technologist, right? When we talk about how that actually works on the camera, you're really not around your patient all that much when they're radioactive, and so dose goes way down. Okay. In terms of patient prep, it's very similar to what we talked about before. NPO 4 to 6 hours. Again, nothing to eat or drink except for water. We talked last time about how this is for gut uptake, right? Hepatobiliary clearance. You still can get some PET or some gut on PET. That is something that still happens. However, there's a couple of things that keep it from being as problematic. So we do keep them off of food for that same purpose. However, remember that when we go from SPECT, which has a resolution of about 12 millimeters, to PET, you're now looking at a resolution of somewhere around 3 millimeters. So because of that difference, even when we get some gut uptake in PET, oftentimes where the heart ends, that apex of the heart, and where the stomach begins and the gut ends, we can still get enough separation to get a good image out of that, right? Because we don't get the gut overlapping and get it in the way. Most of the time, I would say on average, there's not gut at all with PET scans, but when there is, it's rarely problematic. Once in a while, that it's still an issue, and you have to do some of the similar things. You repeat an image, whatever you have to do, if possible. Usually, a doctor directs that. Anyway, I'm getting a little deep on that, but the idea is that we're still going to have them be NPO. Again, we don't want them on anything that's a vasodilator prior to the test, right? Because we're going to use regadenoson, Lexiscan to dilate and do our stress. And then, and I'll also mention right there again, like, I want you to think about the fact that when we're working with a 75-second half-life, we're not going to be exercising these patients on a treadmill, right? There's not enough time to get them on a treadmill, get them up to where they're vasodilating, and then give them our rubidium. If we did, by the time we got them on the camera settled in there, we're just not going to have enough left to get a picture. So, so the vasodilator stuff is very important, and also the caffeine is very important. Again, remember, caffeine can be a vasoconstrictor. Specifically, it binds to the A2A receptor sites, same as adenosine and regadenoson. So again, and caffeine, as I mentioned last time, is a bigger molecule. So even if you have caffeine on board and you try to put adenosine or regadenoson in there, it's not going to bind to those receptor sites. That caffeine is going to stay put. So again, very important with PET because it's literally the only way that we stress in PET. So here's our Lexiscan again, and this is a very similar. It's the same slide that we looked at last time, so I'll briefly go over it. But remember, regadenoson binds to the A2A receptors, inhibits calcium entry, causes that relaxation and dilation of the vessels. Again, no caffeine. It's a bolus dose followed by 5 ml of saline, which is really nice as well because you can just give them that 10 to 15 second flush, follow it with the saline, and then follow it with the radiopharmaceutical. So we talked about side effects last time: shortness of breath, the heart rate increase, flushing, nausea. I think I added on headache on this one. I do have a lot of patients that get a headache with this. Side effects occur in about 30%. Again, half-life 2 to 4 minutes. We can reverse it with aminophylline and caffeine. In our facility, it's our common practice that when we're done with the stress test, we keep them in a recovery room for about 20 minutes while we process through all of our data. Make sure nothing urgent or emergent before we're sending the patient home. At that time, we give them caffeine. We've got like coffee, tea, Coke, Dr. Pepper, or something like that. We'll offer that to our patient just to do that reversal. We also talked about contraindications, which are those second and third degree AV blocks. First degree AV blocks, okay, but when we get into second or third, then that's a contraindication for Lexiscan. And then I mentioned relative contraindications again. Seizure history. We can do a patient with seizure history. Typically, you'll want to talk to a PA or a doctor about this one. It depends on how recent their seizure history is and if they're on seizure medication. Usually, if they're on seizure medication, then we're okay to do it. But you'll want to look at that and have a provider make those kinds of decisions. And then that can be reversed with Valium. If they do have a seizure, it can be reversed with Valium. And then asthma and COPD, you can exacerbate the asthma and the COPD with the Lexiscan. But again, we can use albuterol to treat that. I have a lot of patients that I'll simply ask them if they have asthma or COPD and ask them how bad it is and how much it affects them and how often. And usually based off that, we can even pre-treat. And oftentimes if you pre-treat with the albuterol, then it kind of takes care of it and they never have a problem. But I would say probably 90% of my patients that say they have asthma do just fine. It doesn't exacerbate their asthma and they're usually okay. But if I have a patient, again, that's like, yeah, my asthma affects me every day, it's affecting me earlier today, I constantly have to be on medication, then, excuse me, I'll probably just pre-treat them with the albuterol. I included dobutamine. You're probably not going to use it that much, but dobutamine is one that they will turn to sometimes because it doesn't have the same problem with seizure history. Again, I won't go over all this because I did before. The thing that I would say is that if you can use Lexiscan, I think that's by far the best thing to use. Because remember, when we do dobutamine, I talked about how this protocol works, and you're going to inject every couple of minutes and basically until they can get to the highest tolerated dose. And so, and this one makes people feel like garbage. So it's very hard. Remember, when we do a PET scan, we get our patient on the scanner. We do the whole entire test, rest, stress, everything, without removing them from the scanner. And so, dobutamine, because of how you have to do it, the protocol, it can just be hard to do with them on the scanner, as opposed to Lexiscan, which is a quick 10 to 15 second injection and you're done. So I have seen this done before in special cases, and that was decided by one of our PAs. Because there wasn't other options for those particular patients. So don't see it very often. Every once in a while you might see it, but again, it can work, but you probably won't see it. But I included it on there just for that reason. All right, so let's get into talking about how this works and what the protocol is. So just like anything else, I mentioned on here, of course, verify patient preparation. Obviously, that's huge in getting good results on a PET scan because we have the issues with eating, we have the issues with caffeine. We want to make sure that they're prepped, so everything that we're going to do is going to work. We're obviously going to start starting an IV that we're going to need. Now, this is something different to think about than the SPECT protocol, but you're going to need to hook up your 12-lead EKG and your 3-lead for your gate right away, right? And the reason for that, again, I mentioned just a minute ago, we're going to be doing our stress test with the patient on the camera under the scanner because we don't move them in and out, right? We're going to stress the patient and then immediately start images after we do that. So we have to hook up the 12-lead EKG ahead of time. Now that might cause different ways of having to do it depending on your facility, right? Because at our facility, we've all been trained. This is one of the reasons, frankly, that we were all trained on EKG and became certified, because it really stops the flow for us, especially how busy we are to try to get an EKG tech coming in and all that kind of stuff. So we hook it all up ourselves. We do it all ourselves. We monitor the EKG ourselves. However, I've other facilities in the area that I've been to and worked at where they have a PET scanner, they do it differently, right? They have an EKG tech come in and hook up the 12-lead EKG and stay there and monitor with you. And so those are all things you'll need to think about as you are looking at how your facility does the protocols, being able to line all those things up so that it works for patient flow. But we have to set up our EKG first. So for the resting scan, they're obviously going to be laying on their back on the scanner, arms above your head, just like in a regular SPECT, because we want to get any attenuation from the arms out of the way. Protocols can be different from place to place, but I want you to think we're going to be doing a CT scan as part of this for attenuation correction, and then we're going to have a rest and a stress. The rest is always going to be performed before the stress by nature of how it works and how rubidium is quickly out of the system, right? We don't have to worry about a lot of the things we have to worry about with SPECT, but it's always going to be a rest stress. And so I've seen some facilities where they'll do one CT. They'll do one CT on the way in, then they'll do the rest and the stress, and then they're done. I've seen facilities where they bring them into the camera, so they're underneath the PET portion of the camera. they do a rest, they do a stress, they do a CT on the way out. There's some varying things. At our facility, we actually do a CT on the way in and we do a CT on the way out. One of the reasons that we do it that way is when you stress a patient and you get increased heart rate, you can get anatomical movement and you can get the heart actually kind of shifting its position in the chest just enough that if we were to do a rest CT and then we were to do the stress and then marry it with the rest CT or combine it with the rest CT, that CT, the anatomy may have shifted enough that it doesn't quite match perfectly with our stress scan. And that's what we found over time. So we do one coming in and one going out. Of course, that's going to be based on protocol. It's going to be based on your physicians. Obviously, you're thinking of a LARA. I'm sure in your head right now, if we can reduce the amount of CTs, that's good. We found at our facility that we get better imaging and less likely that we have to do anything over again or repeat anything if we do those two CTs. The other advantage to doing two CTs is that, and I think when we did our physics instrumentation last semester, and we talked about putting a CT and a PET scan together, we talked about the registration and the attenuation correction. I showed you some slides where the CT had some sort of error in it. And when the CT has an error, that can show up it can make it so that the attenuation correction is off and it either adds more counts or takes counts away where they should be and makes it look like there's a defect in the heart, right? So one advantage is that if you have a problem like that, you can choose from the rest or stress CT. If you have one CT that's got an error in it, it's really bad, it ended up with a streaking artifact or something like that, but your other CT is okay, then you can marry them both to the other CT and correct problems that way. And so that's the way we do it. Again, it's going to be dependent on your protocol, but you're going to have some sort of CT, then also the rest and the stress, okay? So going from our protocol, we'll follow it that way. We enter in with the rest CT scan. That's at the front end of the camera. Typically on a PET scanner, you've got the CT at the front and the PET on the back. So we'll pull them through the camera. Most of the time, our patients are of such a habitus that their head kind of pops out the back end. Now we have our rubidium generator. It's on a cart and it's located at the back side of our PET scanner. So when the patient gets pulled through and into the PET position, you'll go back and you'll hook up to their IV, you'll hook up to the generator. Now, a bit of advice I'll give you here, because of all the different mistakes that have been made in our facility, there's two things that have happened more times than should. Techs, when they're hooking up to the IV, they forget to open up the little clamp on the IV, right? That's happened so many times. So we hook them up, we get ready, we hit start on our PET scanner, start on the injector, and we sit there and watch and nothing happens, and it's because it's clamped and it causes an error on your rubidium generator. So make sure that you're unclamping. The other thing that is a really good tip, most of the time when you start a patient IV, you've either started it in a chair before you start it, or you started it while they're laying on the scanner, right? And their arm is out in a normal position. Well, once you start the scan, you get their arms up above their head, right? And so sometimes you can get a little bit of kink in the IV. And we've had more than one occasion where we get them hooked up, the clamp is open, but we give them the injection and nothing happens. It kinks in the IV and we get the same kind of error as if the clamp was hooked. So a really good practice if you're doing PET scans is that once you get your patient back there and you're going to hook up the rubidium generator tubing to the patient, just flush first. Always flush first, because then you avoid any problems. You know your CT or your IV is working great, right? So just flush first, then hook it up. Now, the way that these work is the rubidium generator, it's just a push button start. There are older generators that it's an actual physical button, and then there's some newer generators that it's a screen and you push go on the screen. Again, I don't get into that too much because it could be different at your facility. But essentially, you're going to want to start the injection and start the camera at essentially the same time. Now, there is some variant on what happens at different facilities and how they do this. I have worked where we hit start on the injection and start on the camera at the exact same time. yeah, excuse me, let me go back. You're always going to hit them at the same time, but there are some variants on when you get to the stress portion when you give Lexiscan and how much time you will have elapsed from giving Lexiscan. So I'll cover that in a minute, but essentially you're going to want to hit start on the camera and the generator at the same time. When we get to the data of PET, we're going to talk about some things like myocardial blood flow. And with PET, we were able to catch the blood flow as it's going into the heart and able to do some things with that. And we'll talk about that. So you want to be able to catch that. So you're going to be hitting start on your camera at the same time that you give the injection. Typically, you have about a 7-minute acquisition on a PET scan. That could vary a little bit depending on where you work, but it's going to be pretty close to that. So these are actually pretty quick pictures compared to SPECT as well. And the thing I want you to think about that's really kind of I thought was interesting when I first started doing PET is that remember this is a 75-second half-life, so it goes away pretty quick. So you might ask yourself, well, how do we image for 7 minutes? Well, really what that means is that the bulk of what you catch is at the very beginning of your imaging, and then by the time the 7 minutes is drawn out, most of your dose is gone, but you get that 7 minutes to get enough counts into the cardiac tissue that you get good quality images, okay? So once we've done our rest scan, then we're going to come back for our stress. Now, usually before the stress, again, remember, we already hooked up the EKG, but you are going to want to get a blood pressure on the patient as part of your EKG setup. So you're going to want to check blood pressure. Again, when we're doing stress tests, blood pressure, one of the things we follow with blood pressure, especially for Lexiscan, is that we're going to expect that if they start at it, whatever level they start at, the typical thing you're going to see is for blood pressure to come down slightly. Now, with normal exercise on a treadmill, blood pressure is going to go up probably because of strain, muscular tension, a bunch of other things. But with Lexiscan, it goes down. Now, why would that be? So if you think about how Lexiscan works, we're dilating, right? We're dilating the blood vessels. And in a closed system that's pressurized, essentially when you make that system bigger, when you open up the space, pressure in that space goes down. So you typically will see that. And when you do a stress test and you're monitoring your patient, you'll be doing a few blood pressures throughout the stress. That's what you're going to want to do. You're going to want to see, I started here, I've dipped down a little. By the time we're done, I want to start seeing some recovery on my blood pressure. It's just one of the ways you can monitor your patient. Okay, so we've done our rest. You can check for image quality before moving on to the stress. Typically what that means is that most PET scanners, when you're on the camera, you're on your acquisition station, most of them will have you do the attenuation correction right after the image is done. So that's a great time to look at your CT, and make sure looks like you've got some perfusion. It'll allow you to marry those and then set up all the different recons you want to do. Typically you'll have like a rest, excuse me, a perfusion recon, and then you'll have like a gated recon, and then what's called MBF, which we'll go over. And so you'll start those recons, and those will be processing because it's a lot of data, so they take some time. And then that way you can go and move on to your stress. Okay. So in terms of imaging length, it's the same picture that we did the first time. The other cool thing is that we're going to give the same dose. So I mentioned on here, typically you're about 20 to 40 millicuries. That can vary as well depending on what your facility does and what they set up, but this is kind of typical for rubidium. And some places do it based on weight, some places do it based on just like BMI. At our facility, we've actually gone to a system where we'll take one of the slices of the CT and we'll actually measure the attenuation correction, and we'll do it based off an attenuation correction number. And so there's multiple ways to do it, but it's usually based on weight or patient thickness in some way or another, about 20 to 40 millicuries. Now, the cool thing is that when you're doing this, remember 75-second half-life. So by the time the rest is done and then you get a blood pressure, you don't have any activity in your patient anymore. So remember when we talked about SPECT, we had to do a lower dose, like an 8 millicurie dose for the rest and like a 30 millicurie dose for the stress. And the reason we were doing that is because that stress dose had to overpower that rest dose so that we could get an accurate view of what the stress looked like, right? So in this case, we can give them the same dose both times because, again, there's not going to be anything left from the rest by the time we do the stress, okay? So for the stress, basically what you're going to be doing is you're going to be giving the Lexiscan again 10 to 15 second push, followed by 5 ml of saline. And then once that's done, then we're going to start our injection and start our camera. Okay. Now, this also can vary slightly from facility to facility. This is what I was telling you a minute ago. The peak stress of regadenoson, if you look in the packaging, it says is between 60 and 90 seconds. So our facility has kind of morphed on this over time. We used to give Lexiscan, give the flush, and immediately start the camera and the generator. We've actually now our physicians have decided they want to go up to 90 seconds. So in this case, what we do is we give Lexiscan, we give the flush, and then we have a timer on the back of our camera, and we wait about 90 seconds before we give the injection of the rubidium so that we can ensure that the Lexiscan is at peak stress. Again, that's going to vary from place to place, but it's going to be something in that kind of range with Lexiscan. Some other caveats that you might have doing this, some of the older cameras and some of the newer cameras are a little bit different on the way that you can start the imaging. So when we first got our first PET scanner and we were doing cardiac, the acquisition had to be started from the tech room, right? So that meant that the person out there giving the Lexiscan and hooking everything up had to have a way of saying, it's time to start, so they could start the generator at the same time that the camera was started. So what we used to do is we used to give the Lexi, give the flush, and then we'd step to the side of the camera. We'd give the tech in the tech room a thumbs up. They would give you a thumbs up, and then they would start the camera at the same time you hit go on the generator. And for a long time, we did that. And that's typically, if you don't have a way of starting your camera in the scanner room, then that's what you're going to have to do. You're going to need two people to be able to coordinate that. Because again, you want to be able to start those at the same time. We're going to talk in a minute about MBF. You don't want to miss the blood flow coming into the heart because we're going to do something with that data. Now, the newer scanners, both of ours are newer scanners now. The newer scanners will actually have a button on the front and the back of the actual scanner itself, so you can start it yourself. And so that's what we do now. So our protocol now, where I work, is we'll give Lexiscan 10 to 15 second flush. I'll give the saline 5 ml. I start my timer. I wait the 90 seconds. As soon as it hits 90 seconds, I'm going to start the camera, and then I'm going to start the injection of the rubidium. And that way we catch everything that we need to. Again, that could vary slightly, but that's essentially how you'll do these. So there's a little bit of variation, but again, just remember we're going to be doing a CT, we're going to be doing a rest, we're going to be doing a stress. It's all going to be done on the camera. We have to hook up our patient to 1280 kg ahead of time. Okay. All right. Any questions on that? Okay.
I was just gonna kind of add, at my hospital, we will inject the Lexi and then we'll flush. So the Lexi will inject within 10 seconds and then we flush for 10 seconds. And then when we first start that, we start a 1 minute timer. So then once the timer goes off, we start the camera, wait 5 seconds, and then we start our rubidium.
Okay. Yeah.
So it's kind of interesting to hear like different protocols, but
yeah, and I again, it's kind of facility based, and PET is new enough in terms of, it's been around for a while. Doing cardiac PET's been around for a while, but at the same token, using rubidium through a generator and all these things, they're kind of changing as we go, right? Like even in my facility, like I said, we used to immediately inject everything. And now we've spaced it out. And so things change from time to time. I've seen a few different protocols just at my facility. But again, it makes sense what you said. If you inject Lexi, flush, you have a minute wait time. We actually went through that same thing where our PA, that's kind of the one that controls the protocols and works with the physicians, we did a minute for a while too, and then he extended it out to a minute 30 to 90 seconds. So yeah.
does that, with the 90 seconds, does that help you see like get a better MBF usually, or?
That's the claim. Our PA, his name's Steve Mason. He does a lot of research and crunches the numbers on what we see. And that's the reason he moved it to 90 seconds, was that we were getting better peaks on our MBF if we waited, because what he explains is you're getting the best dilation at about 90 seconds. So if we hit it at peak dilation, then we're getting really good peaks on our MBF, and we're able to get better MBF numbers. Again, we'll cover some of that in a minute for those of you that are like, what are you talking about?
Yeah.
But yeah. So yep. But what you're doing works. And again, it's like anything else, right? You
Okay,
follow
good
the
to know. I'm
protocol.
gonna talk to the techs and kind of see
Yeah,
what their thoughts are.
yeah, for sure. That'd be cool. Yeah, thanks for the question. All right, is there anybody else? If not, I'll kind of keep going here. I want to look at some images, okay? So here's PET images. This is a normal perfusion on rest and stress. Again, we have the stress on top, rest underneath. Couple of things I want you to notice here. Now, right off as you look at this, you might not say to yourself, well, this looks so much better than SPECT. Some of you might, again, if you've been looking at SPECT images. But a couple of things I want to point out about these images is, one, notice how we really don't see any gut. There's like something down here that's showing up a little bit, but we've got a lot of separation there. There's no gut. You'll also notice on PET that the what they call a background ratio, or in other words, how much radiation is in the background coming through, is a lot less than a SPECT. When you look at the SPECT, you typically have more unless you've applied some kind of filter. But there's the background, the ratio from what you can see of the heart to the background is a lot more crisp. Again, remember, this is 12 millimeters to 3 millimeters. Sometimes you don't really necessarily recognize that with the naked eye, but because of how much more clear the background is, again, the gut's out of the way, that's where some of that comes into play. One thing I'll point out on here, if you start looking at these images, and like I said, you have perfusion all throughout the heart. If you look at this horizontal long axis right here, you'll notice that on the stress, it seems like it's a little underperfused in the apex. It's very common in PET to have what's called apical thinning. Remember, when you're doing a SPECT, you have that 12 millimeters of resolution coming down to a 3 millimeter resolution on PET. And the apex can be notorious for looking a little underperfused on stress. And the reason is because, again, remember, the apex is the last place the blood flow gets to. So when the heart's contracting, systolically contracting during stress, and it's contracting more often, sometimes you can get an underperfused look in that apex that isn't actually because there's a blockage or because there's something going on. It's just because it doesn't get enough time in between to get blood flow down in between those contractions. Typically, you won't see it as like a missing section. Like if this was really dark black, then no, that's not apical thinning. But you'll see apical thinning here. And most cardiologists will mention apical thinning, but don't necessarily consider it like an issue, or, it's not like an ischemia or anything like that. It's a normal thing that happens. You don't really see that much on SPECT. It can happen, but you don't see it that much because your resolution being 12 millimeters, you don't get that. That's where you're seeing such a tiny little portion there. If it was SPECT, it would just kind of blur over itself and you wouldn't see it. But with PET, you do see it. So that's what you see there when you notice that little bit of reduction at the apex on the stress. It's just apical thinning. This is still pretty normal. And I'll show you, let's see, here's another one. This one really doesn't have it as bad. And when we look at some polar maps, I'll show you some of that apical thinning, what it looks like on a polar map as well. But here's just another example, just a little bit different shaped heart. Looks like we had kind of a short stubby heart here, and this one's a little longer. But again, you'll notice a little bit less background. This one has a little more than the other one, but again, nice, crisp, good images. I want to talk about polar maps. We mentioned this before, but I want to bring you up to speed so we remember as we get talking about these next few slides. Remember that the polar map is if we took that left ventricle out, right? And then we flattened it kind of like a camping cup, or we just flattened it out like a map, so that in the center is the apex. And as we work our way out to the base is all around the outside edge, right? So apical to basal. And remember that we divided it into this 16 segment map that corresponds to anatomical areas of the left ventricle. Each of these is worth 4 points when we start to look at the maps, and it will vary. It will show you how much activity is missing based on the point value. And then we also have polar maps again that are based on the coronary arteries and the anatomy and the areas that those coronary arteries supply the blood flow with. So I just wanted to bring that back to your mind before we kind of go to the next slide here. So again, so here's some polar maps that we're looking at. There's like a shortened version of the slices up here that we can look at. This is where I wanted to point out that apical thinning. You notice this is a normal stress test. We see it in both, right? So you might be tempted to be like, oh, there's a slight defect here and it's fixed, right? Meaning that there's a reduction in blood flow. It's some sort of partial MI. But in this case, it's not. And again, your cardiologists usually mention it, but they don't necessarily call it an MI. But that's what you're looking at. That's that apical thinning that I was talking about. Okay. Let's go to another one. Actually, while we're here, let me explain one other thing. The other thing I'll show you here, and it'll be more apparent when we look at ones that are actually have some blood flow missing. But you'll notice this SSS, SRS, and SDS. SS stands for some stress score, some rest score, and then some different score. So when the computer scores the areas that are missing, and notice the computer knows that that's apical thinning because it doesn't score anything in the apex. But as it scores here, it's going to score what a number value based on reduction of blood flow for the stress and the rest. And then over here is the reversibility. In other words, it will compare them and say, where's their actual ischemia and where's there not. Okay. Here's another view of polar maps that you get with PET data that isn't necessarily on spec data. What you have here is, again, we have what you'll notice this little ring on the map. You'll notice there's no 16 segment. There's nothing based on coronary arteries. It's just the map itself, or just the polar plot itself. And then you have what this is called a circumferential profile. So this little ring. And I wish I could just be on the software moving things around and showing you guys, but you can essentially move this ring in and out to wherever you want. And what will happen is that over here on the right, you have each point of that ring is plotted out, and it gives you a percentage of how much perfusion is there. So from 0 to, in this case, we're somewhere in the 90% perfused in that tissue area. And then you'll notice that it starts lateral, inferior, septal, anterior, back to lateral, right? So in other words, the first point on the plot is here, and it starts working to inferior, then to septal, then to anterior, then back to lateral, okay? So each point is plotted along this map, and it's showing you exactly the percentage of perfusion there. And then this blue that you see here, what this is this is it's like a Midwestern average of patients from 45 to 70. So they just took the data of the United States Midwestern average and said, this is what the typical perfusion looks like in a heart scan for someone 45 to 70, an average. And so what it does is it just compares what you see on your plot to the average American person, right? And gives you a profile. So this allows the doctors to actually, if they see an area where there's missing blood flow, they can kind of pinpoint it. They can look at percentage of where that looks like and compare that to what should be average. Okay, and so that's another kind of cool data points that you can use. Also, we're going to get ejection fraction data. Now, remember when we did our MUGAs, right? We got ejection fraction data, and that's because we were measuring the amount of radioactivity inside the ventricle itself. In this case, they're going to still measure the ventricle, but the computer is able to measure the size of the ventricle and its contraction based on the myocardium, rather than the volume that's within the ventricle, right? And so most of the data on here is really similar to what you would get when we did our MUGA scan, right? So you have ejection fraction, you have an actual contraction curve here. Over here you have wall motion. So what they've done, this is very similar to what we saw in wall motion over there, where they've essentially given counts to where the motion occurred. Remember, we talked about how when the left ventricle contracts, it mostly contracts from the lateral wall in towards the septum. And so again, that's exactly what you see here, is not a lot of contraction towards the septum, but a ton of contraction on that lateral wall. And that's going to show you the difference. It's also going to plot those out in the 16 segments and show you where motion occurred. And so very, very similar data to what you would see here. But again, we can get our EF data. Also, we have the synchrony. Remember, we talked about that. This is also similar data to what you had in your MUGA scan. Just to kind of remind you here, what you're seeing here is essentially a contractility histogram. And so this is like force of contraction and when the contraction happened in time, right? So you can see that this highest color looks like it's the hardest force of contraction. If you go over to the map where it matches the color, that makes sense, right? Because most of that color is over here on that lateral wall, right? So force of contraction is mostly coming from that lateral wall, okay? So very similar, again, to the data we had before with MBF. Now, let's talk about MBF. I've been kind of leaning towards this the whole time. Let's explain what MBF is. So I'm going to put out a question. My question is what, and I'll try to get someone brave here. What is myocardial reserve? Who wants to try to answer that? I put you all to sleep.
It's the amount of contraction that's left whenever it reaches its peak.
Okay, that is I'm not going to necessarily say no because I think you're right in a way. And you're exactly along the right idea. But I'm gonna slightly nuance that, and you'll see that you're not wrong, but we're gonna add a little more to that. So I want you to think about, again, when we first talked about perfusion studies, and we talked about what are we doing? When we stress a patient, what are we doing? If you remember from the last lecture, essentially what I said is that when we're stressing a patient, what are we trying to do? We're trying to get the blood vessels to dilate, right? And that is increasing blood flow into the cardiac tissue. So what myocardial reserve is, you could kind of think of it as at rest, you have a certain amount of blood flow per square gram of tissue that's in the cardiac tissue. And then at stress, you should increase that. That ratio between what you started with in the cardiac tissue and what you were able to get to during stress in the cardiac tissue is what we call myocardial reserve, okay? It's a measure of the blood flow increase. I started with a certain amount of blood flow in the cardiac tissue. What do I increase to when I vasodilate, okay? And what MBF is, myocardial blood flow, is it's a measure and a ratio of that difference between where we were when we were at rest and where we were at stress. So if you look at, again, this is another one where I wish we could just sit down on some software and actually go through it, because looking at static images isn't as effective, but it will give you an idea. So typically when you start to look at an MBF and you're doing processing and getting it ready for a doctor, it's going to allow you to go through a broke up cine. So you're going to start with when you started that injection and you started your camera all the way to the end. You can go through steps, and typically your camera will allow you to go through about 12 different steps of it coming in, right? So what you see right here is you see the bolus of your dose, your rubidium, coming into the left ventricle, okay? And you're seeing the different slices just like you would normally see them, right? So you have your axial, your horizontal long axis, and your vertical axis. And so what you're seeing is this bolus dose coming into the ventricle. The reason I mentioned needing to catch that is because what we're going to do to get our MBF is we're going to measure the activity going in to the ventricle, okay? And that's what your software will allow you to do. Most of the software lets you manipulate everything so that this dose is going straight into your ventricle. What this particular software does is it measures every one of those frames coming in right at the base of where you kind of see this T right here, this inverted T. It measures the bolus coming in. So if you get your picture up and that bolus is over here or it's over there, essentially most of your MBF software will allow you to align that bolus so that it's going straight into your ventricle, and that your software is lined up and knows where the beginning of that ventricle is. Okay, so that's what these have done. This is our rest and stress. We've lined up the bolus, and the camera will measure that. Then what it will do is it will go to the very last frame, which is the frame where you should have that bolus has now gone into the ventricle. It's traveled through the circulatory system and come through the coronary arteries now and into the heart muscle itself, into the myocardium. And that's what this picture over here represents, is now the camera is going to draw an ROI where it thinks it sees the myocardium, okay? And essentially what this computer software is doing now is it's going to compare the dose that came in and how the count activity there to the dose that reached the myocardium and compare the count activity there. And then what it does is it makes a ratio based on that. Not only does it just make a simple ratio, but it also makes a ratio based on how the stress did from the rest, right? So what you see down in this little chart is it gives you this ratio of, and it breaks it up for the LAD, the circ, the RCA, and then what they call global, which is just the whole heart. And it does that for both the rest and the stress. And then it compares the difference, right? That's what our myocardial reserve is. It's the difference between what you had at rest in the tissue and what you had at stress in the tissue, okay? And so typically what you want to see is your reserve. When you come over here to reserve, you want to see that above a 2.3 is considered normal. Now, that's not going to be on your test. Don't worry about it. It's not going to be on the test I give you. It's not going to be on your board. So this is for you as techs, understanding that a normal is about 2.3, and then it goes down from there on being normal, right? But you'll also notice you break up these into the different coronary artery divisions or areas of the heart that it feeds. So I want to point out some of these just to kind of give you an idea of the data that you can get here, right? So if you look at the rest here, when we're looking at LAD, and we can look at circ too, both these are good ones to look at. But you look at LAD, on the rest, you got a 0.58, okay, so a little lower ratio of blood flow. And then on the stress, you went up to a 1.02. So you can see there was some increase in myocardial reserve. It went up, right? And you'll notice that though that when we come down here on the circ, we started at a 0.67 and we went up to a 0.89. And so if you look at the reserve numbers, when it compares those two, you have a 1.82, and then this circ comes down to a 139, RCA is 173. So you'll notice RCA and LAD are pretty similar, but that circ's a little bit dropped for them, right? 1.3 is compared to like a 1.8 or 1.7. Well, if we look at these polar maps of the NBF, we can start to make sense out of that, because the circ, again, your circ area is going to be over here, and that's kind of where you're seeing some stuff missing, right? You're seeing some blood flow in some of the other areas, but you're seeing some missing in the circ there. And so that's what the NBF data does, is it allows us to look at and compare and look at myocardial reserve and see what should be in there. Now, one thing to think about is you can't do this on SPECT. And the reason you can't do it is because, remember, when we do a PET, we're acquiring, or let me go back, when you're doing a SPECT, you're acquiring it a step and shoot all the way around, and then you're making images out of those separate images happening at different times, right? Whereas with PET, we acquired this bolus in all three orientations. We're able to look at all three orientations at once because we're imaging 360 degrees all at the same time. So you really can't catch a bolus and be able to measure it and quantify it on a SPECT. You can catch a bolus on a PET and be able to perform this NBF data. Now, you might ask, well, okay, so I kind of see similar data. Like I could probably see on the perfusion slices that if it was this same patient, I could probably see that they were missing some in the circ. So is it really that big of a deal? So let me give you a couple places where this is really big and really matters a lot. And I'm going to go back to some slices to kind of make this point. Let's look at these first slices we did. So remember how we came when we looked at this and we're like, hey, look, this is really pretty. There's perfusion all throughout on both rest and stress, and we can see that, and it looks great, right? So remember that, and we've talked about this a little bit before, but remember when your software brings an image up for you to view, what it does is it finds the hottest pixel, and on most of your Nuc Med stuff, it makes that hottest pixel kind of a bright white, and then pixels going down from there, it goes into like a grayscale, right? All the way down to black being no activity. So white to black, hottest pixel, and then it measures everything from there and kind of levels it out so it's pretty for your eye. Well, in cardiac, we're doing the same thing. We just have a color scale. It's called the 10-step color scale or a spectrum scale. And so it makes the hottest pixel white all the way down through kind of your oranges, yellows, all the way down to kind of your purples and blues until you finally get to black, right? So what that means is that if I were to take and window one of these two images up, I could make it look really bright and white and make it look like it has a lot more activity than the other one. Or I could window it down really, really far and make it look like it didn't have a lot of activity, okay? But the computer is trained to like level it out for you. So here's why this matters. What do you think would happen if a patient came in, and remember, the three vessels general areas that we're looking at is LAD, circ, and RCA, feeding that left ventricle. What if you had a patient that came in and they had a similar size, similar functionality blockage in all three of those vessels? What would your image look like? Any guesses? If you had three vessel disease, similarly reduced in all three vessels, what would your image look like?
It would look normal
Why?
because they'd all be the same color.
Yeah. And your computer would likely raise that image to looking just like your other image, right? And so that's the one downfall is you can get three vessel disease. You can also get what's called microvascular disease, which is where essentially your three main vessels are mostly open, but as you get into the tissue itself, you can get disease microvascularly where it kind of stunts everything in general. So what that means then is that if we have that issue, going back to our MBF pictures, that's where this is going to be really important to be able to measure MBF and actually see the numbers, because again, this is quantified data of actual activity and actual numbers when it does these ratios, right? So on that image that we mentioned on our, we've made up this idea in our mind of this image we're looking at, but let's say we bring those images up, they look the same, but then we come to our MBF data and our rest, let's say we get these same numbers, our rest scan is all 0.58, and then our stress scan is also 0.58, right? What that means is we didn't increase blood flow at all. We didn't increase blood flow. And that's going to tell you you've either got three vessel disease or that microvascular disease, okay? So this is where MBF can be really, really helpful because you can have patients that are very diseased that have normal looking images. And on a SPECT, there's simply no way to tell that or really tell the difference. However, using this MBF data, you can see some of that. So hopefully that made sense. If there's anybody confused, let me know because we can try to further clarify. But all right, I'm going to take that as a no. Here's another screen. This is just similar data. It's just a different software. We've gone through a couple different software, so I just included them both. But here's all your numbers over here. So kind of similar data on here. Let's look at a couple of slices. So this is a positive scan. You can look at here, and you can see where you've got some defects. Anyone want to be brave and tell me where this defect is? What vessel's likely involved and where the defect is?
LCA,
What was that?
the circumflex.
Yep. This looks like circ to me. I would agree with that. Where is it located anatomically? Do you know that?
Left backside of the heart.
Yep, we have names for those. We have names for those on when we talk about a heart. Here, let me refresh y'all's memory. I'll give you a look at this really quick. Any guesses now?
Mid inferior.
Could be. Let's go back over here. I'm thinking. I think part of it was that, yeah. So we're kind of on that outside edge. and it's probably mid. It's probably inferior lateral. I would add the lateral part to that. It kind of comes out. And one thing I want you to think about when you're looking at these, and this can be, my brain took a minute to do this when I was first learning all this, but remember that your slices start from apex and then they go towards the base, right? And so I think you're probably right. Right out here, we're all the way out to the base. So this would be like baso inferior lateral. But if we're down in here, you're right, probably like mid and then inferior lateral, right? And you can see that some of these slices down here as well. But just remember that you're starting at the base and going out to the, or excuse me, you're starting at the apex and going out to the base on these. And then same thing here, like you're starting septal going lateral, starting inferior going anterior. So you kind of have to like learn how to think 3D with these. So I think this is the actual polar maps here, and so we can kind of see that same thing here. Now, this is kind of cool because can someone tell me based on these polar maps, do we have a fixed defect? Are we reversible? What are we looking at here? Any ideas?
Looks like it's irreversible
Okay, so some reversibility. Where do you see the reversibility?
because you can see it both on the rest and the stress, but it gets worse on the stress, so it looks like it can be opened back up.
Yeah, exactly. Who was that? I didn't see who was talking.
It was me.
Curtis? Okay. I had to look over at my other screen to see you guys. Yeah, you're thinking exactly right. So what's cool about this is that, you know, we've talked so much about like it's either reversible or fixed, right? But you actually see both in here. If you look at these at kind of just mostly inferior here, you look at your numbers and you kind of get inferior on both of them. But then on the stress over here, you've also got some stuff happening in the apex that's not on the apex on the rest. And then it kind of comes up more going laterally towards anterior, right? And so we're kind of seeing both like this, that there is certainly some sort of fixed defect here. So there's likely part of this heart tissue that has had a previous heart attack and is gone, that is dead myocardium, right? But then there's also this area now that's starting to have ischemia, right? And that's where we see that kind of inferior lateral area. And again, it looks like it's basal and mid on this particular area. Now you'll notice here I mentioned before the SDS, the SRS, and the SDS, the sum stress score. So again, it gave this a score of 20, gave this one a score of 8, so we can see the difference is about a 12, right? So a sum score difference or the reversibility. And that's the other thing this map shows, which is kind of cool, is it fills in for you with this grid pattern where it sees the reversibility or the difference in those numbers. Because remember, difference in numbers is going to mean ischemia. Having matching numbers is going to mean infarct, right? And so, again, this really narrows it down and says, that as far as the computer is concerned, this black area is where it sees an infarct. The rest of this area it's seeing as ischemic, okay? Really good data for cardiologists to look at because then we can decide, okay, we go to the cath lab, what are we likely going to be able to do with this patient? Well, probably you're going to be able to perfuse with a stent or whatever. Probably most of this tissue with maybe a little bit here being unperfusable and dead tissue, right? So kind of cool what you can see and what you can get off of the data here. Here's another one. Now this is kind of cool because this is where it helps to think about when you're looking from apex to base, knowing you're going from apex to base on your slices. Because you'll notice here, if you pull this one up, you look at the rest scan right here on these short access images, and you're like, oh, rest looks great. Oh crap, look at this. The stress looks terrible, like it's reduced everywhere and we're in trouble, right? And you might think by looking at just that image there, the whole heart is not getting anything. Now, again, that's not the case. Remember, we're apical to base. So as you start following this out, you see that you have perfusion towards the base, right? Where you didn't kind of up towards the apex. Well, if you go to look at your other slices, like look at the horizontal long axis, well, now you can really see that's exactly what's going on here is you have this apical defect with both the lateral wall and the septal wall getting perfused, right, towards the base. And so again, that's trying to understand how you're looking at it. And you can see the same thing down here. So here's the polar maps from this one. Anyone want to give a guess on this one? What areas they think are involved? What vessels? If we took this guy up to the cath lab, what would be your guess? Come on, guys, don't leave Curtis hanging, man. You can talk too, Curtis.
Well, it looks like they're all affected at some point under stress.
Okay. I think that's acceptable to say that that's a possibility. If I forced you to choose one, what would it be? If I said you had to choose one?
Is that the RCA?
So
That one that you're pointing at?
RCA is here. So
No,
this
that's the LAD. I'm sorry,
Yep,
LED.
you're good. And don't feel embarrassed or anything. Like, it takes time to get these in your head. So thank you for being willing to just throw it out there. But you're right. LAD, it looks mostly like LAD. One thing I like about these particular polar maps that you'll notice, and you probably said all because you're seeing a little bit of it in everywhere. Now, what these maps do is they say, okay, everyone's anatomy is the same, but it's also varies, right? And so you'll notice that it gives LAD up here, and it has this area where it's likely all LAD, including most of the apex. And then there's area where you have like the RCA, for sure RCA, for sure CIRC. And then you have these areas in between. And essentially what that means on this type of polar map is that this could be some involvement in both those areas, right? So if I had to guess here, I would say LAD is probably right, but I would think unlikely that we have some CIRC involvement because it's just such very little in that CIRC area. It's likely that their LAD is perfusing all the way over into these areas. This one, though, is a little different. It makes me wonder if maybe we could have some RCA here, because if it were just barely into the RCA territory, I'd be like, it's probably, I bet this is just an LAD. But again, we don't know for sure. Now, the other interesting thing is you notice that a lot of this is towards the apex. And remember, on our slices, we could see that the base was very perfused, right? So what does that mean about if we picked LAD and we said this is located in the LAD, what does that mean about where along the LAD that blockage or that narrowing is likely to be located?
It's toward the end where it tapers off.
Yeah, exactly. Who was that? Someone talking.
That was Janine.
Janine, thanks. Yeah. And why do you say that, Janine, looking at these pictures?
Because the base has perfusion, it's all lit up, but more toward the center of the graph is where it goes black.
Yeah. So if we think about LAD comes off up near the base, right? The base gets perfused, and then the coronary arteries come down and around to the areas like the apex, right? So if you think about it, if we are missing our apex and we have our base, it means blood flow got to the top part. It's got to be somewhere mid to apical where that blockage is occurring, somewhere in the LAD. So if I were to have to bet on this, and these guys got sent up to the cath lab, I probably should follow up on this patient and find out, but I would bet you've got a mid LAD lesion on here that's somewhere mid and then is blocking everything going down. That would be my guess. Okay. All right. We're going to go and talk about viability next. So that's PET. Anybody have anything else they wanted to ask on PET? Okay. Why don't we do just like, we don't have tons of time left, but let's just do like a 2 or 3 minute break. Let's just give it a couple minutes. Anyone can run to the restroom or whatever. Let's do, I don't want to take too long, but let's just do like 2:43 or something like that. 2:42, 2:43. Okay. All right. Hopefully that wasn't too short. Hopefully most people are back. You guys okay to get starting again?
Yeah, I'm good.
Okay. So we've got a couple types of scans to talk about. This won't take as long as talking about PET, but we'll kind of get into viability first. So I put the question on the slide, what is viability? But I actually think it's more instructive to answer a different question first. And that's what is hibernating myocardium? Who wants to take a stab at that? No.
Muscle that's not normally used.
Say that again.
Muscle that is not normally used.
Okay. I can take that partially. Yeah. Um, it it is muscle that is not being active. We can say that. Any other ones? What's hibernating myocardium? I would say that, Chris. I would say it's lost its kinetic energy or its kinetic ability, its motion and movement. Well, that's true. Why is it that way? Is part of the other thing I want answered with what is hibernating myocardium.
Because it's got a limited blood supply.
Yes. Um, I found this picture. You guys probably see it on your slides if you printed them out, but I found this picture a few years ago and just thought it was funny because when I was in your spot and I first heard about hibernating myocardium, for some reason a bear hibernating is exactly what came to my mind. So this is kind of a dorky image, but when I saw it, I thought it was kind of funny. There's your hibernating myocardium there. Um, but essentially, what hibernating myocardium, you were right in the fact that it's heart tissue that it isn't moving. But the reason it's not moving, in other words, it's lost its kinetic wall motion, is the way you would say that. And it's because it's hypoperfused, so really, really low blood flow. Typically, it's really low blood flow because it's had ischemia over and over and over again to the point where it's just gotten so low in blood flow that it's lost that kinetic motion. Now, when you do a scan and we pull up and we say we have a fixed defect, right? We have an issue where we see a defect in the rest. We see the same thing in stress. Most of the time, we're going to go ahead and the cardiologist will read it as an infarct. Now, remember, infarct means there's nothing there. It's dead. There's no blood flow to that area, right? The definition of infarct is no blood flow leading to cardiac death of that tissue. And so when we say what is viability, what we're trying to answer with viability is the tissue actually dead and getting no blood flow, or could it be this hibernating myocardium that is just still alive? The tissue's alive, but it's so low in blood flow and it's been that way for so long that it's lost the kinetic wall motion and appears to be an MI, appears to be dead. Okay, so a lot of times when a doctor orders a viability scan, they're just simply trying to answer the question like, okay, this looks like an MI. If we go in and try to do anything, is it going to be a lost cause, or is it worth trying to go in there and seeing if we can reperfuse this tissue in some way? Whether that be from a bypass or stent or whatever we can do with this tissue, is it worth going after, or do we need to just assume it's dead? Can we answer that question? Okay. So I'm going to talk about the thallium protocol and then FDG protocol with this. So I bring up thallium and its characteristics again. Again, I won't go through them all, but I'm going to highlight a few of them that are important on this. One of them is that it has a 73-hour half-life. So it's in the system for a long time, which obviously isn't great for patient dose, but we're going to use it specifically for that reason when we do the oh my gosh, I can't think right now. Sorry, back over. When we do the viability. The other thing we need to remember is that we have redistribution. Remember I talked about how after about 10 or 15 minutes, the thallium will wash back into the vasculature, okay? The reason that redistribution can occur is because going into the myocardium is a certain percentage. No, I'm not going to say it that way. I'm just going to confuse you. The reason the redistribution matters is that it will come out of the myocardium or redistribute based on blood flow. Okay. So what that means is that if you have great blood flow, it goes into the myocardium, it does its thing, and then 15 minutes later, it goes out because of good distribution of blood flow as well. Okay. And so kind of keep that in mind. And then remember that it's proportional to blood flow, which kind of answers that same question, that thallium goes in proportionately to blood flow, just like all of these. So if you're going low blood flow, it's going to be a little bit. If you're going great blood flow, it's going to be a lot. And the redistribution is going to also be able to get back out into the vasculature based on good blood flow as well. Okay. So what that means is you can do, and I have this exact slide up before. This is our stress rest thallium protocol. And so I won't go over that again. So you have remember, you do your stress first and then you do your rest. And the reason you can do that is because of the redistribution. So the other thing that you can do, that you can tack onto the end of this, if you do those two things and you have what looks like a fixed defect, then the doctor can add on viability without you having to do much more. And the reason why is because you can simply have your patient come back 24 hours later. With this protocol, you can give additional thallium before they leave to make sure there's plenty in the system. You don't have to. But essentially what happens is when you come back 24 hours later, redistribution cycle has occurred multiple times. And what will happen is that, remember, we said that hibernating myocardium is tissue that is really low in blood flow. Okay. So what that means is that over time, thallium has been finally able to get into that tissue if it is getting that really low blood flow. Okay. You wouldn't have seen that right away because the blood flow is so low that it couldn't get in there. But over time, over a 24-hour period, and remember, again, this is why I highlighted 73-hour half-life. You got a lot of time that thallium is in that patient's body, right? So by the time that 24 hours has gone by, there's been enough time that some of that thallium has got into that hibernating myocardium that has the low blood flow. And then the other advantage is with the low blood flow, it's not going to redistribute out as well because of the same issue, the blood flow coming out. Okay. And so what that means is you're going to have a little bit of that radioactivity in a small amount in that hibernating myocardium, and then you can image it. Now, when you're imaging this, one caveat is going to be that you could have some uptake into the tissue as you saw it before. So on these, it can mean that you have to brighten up your image until you see if there's anything in that infarcted or what appears infarcted area. But oftentimes too, there's been so much redistribution that you won't get a lot in the normal tissue, but you will see it in the tissue that's hibernated, again, because it doesn't have good blood flow going in and out, and so it's kind of stuck in there a little longer. I don't have pictures of thallium, to be honest with you. I've not done ever in my career a thallium protocol for a viability, but again, still on the board, so I'm giving it to you. Anybody done a viability with thallium? If you have an area that doesn't have PET, then you're kind of have to do a viability with thallium. But anybody experienced it at all? Okay, that's what I kind of thought. I thought that would be a no. So that's the idea with it for thallium. Again, you don't have to do a lot extra. You're just going to do 24-hour imaging and look for uptake in those hibernating myocardium areas. Okay, let's get into the FDG. This one's a little more exciting. It's a little more involved in how it works. And so we'll talk about FDG. Now we've gone over FDG you've probably gone over these same things in other classes and things, but again, cyclotron produce, positron emission, right? We already know that. We know the 511, 110-minute half-life. Okay, so a little bit longer half-life than a lot longer than rubidium. Crosses the cell membrane by glucose transporters. This is important, right? This is why your oncology studies work, because cancer cells are super active and they're high blood flow. And so they like to go after that sugar. Distribution in myocardium is proportional to glucose metabolism. That's why it works in the cancer cell as well. So you got good blood flow to the cancer, You also, glucose metabolism, it likes to eat that sugar. It loves it, right? So this is going to be important as we talk about this protocol with FDG. And then I talk about distribution peak at about 45 minutes. Now in the myocardium, the best time is around 2 to 3 hours. The myocardium, it peak distributes around 45 minutes. Myocardium can take a little longer. It also depends on someone's ejection fraction and how well their circulation is, but it can take a little bit longer to get into cardiac tissue, and you'll see why as we talk a little bit more. You can get normal distribution, of course, in brain, bladder, myocardium, and then probably somewhere around 6 to 8 millisieverts for this test. All right. So let's talk about why this works. Okay. So your myocardium, it likes, what it prefers to use for its metabolism is fatty acids. That's what it wants. Okay. However, it will also use glucose if it can't get the fatty acid, if that's not available. So it preferentially wants to metabolize fatty acids. Okay. When you get an increase, or excuse me, when you get a decrease of blood flow to an area in the myocardium, what happens is you get low oxygen in that area. Now, fatty acid metabolism has to have oxidation, okay? And I won't go into that, but if you want to remember that, go back and look at like Krebs cycle and stuff you've learned in, previous to this. But it needs oxidative metabolism. It needs high oxygen for the metabolism of fatty acids. Glucose does not need high oxidation to be able to go. So hibernating myocardium, being low in blood flow by nature, has a hard time using free fatty acids. Essentially, it can't use free fatty acids for its metabolism. It has to use glucose. Okay, so it's going to want glucose by nature. So the idea here is that we're going to try to get the metabolism of the heart to be based on glucose and not on fatty acids, so that when we give FDG, we get an attraction to our cardiac tissue with FDG. Okay, so and I kind of put that down here. The idea is to get myocardium to crave glucose. Then we're going to starve it from glucose. Then we're going to inject FDG. Okay. I had a well, let me tell you this, and then I'll tell you what a student said once. It was kind of funny. But essentially for the protocol, you're going to have the patient fast. It's about a 12-hour fast. The reason we're having them do a long fast is because, again, we want to make it so that their body is kind of needing something to metabolize, right? So the fast is for that purpose. Also with these, you're typically normally going to obtain a rest stress study. Now, a lot of times if they're doing viability, they've already done a rest stress perfusion scan within the last little while that's caused them to ask the question on what appears to be an MI, is this viable? So they've already done one, but if they don't, then you're going to do one of these with it, because again, the whole nature of hibernating myocardium is it's low in blood flow. So we have to ask the question, is it just hibernating or is it dead? So we got to answer the dead question apparently first, so we have something to compare it to in the end, right? So that's why we do our rest and stress. You're going to draw a baseline glucose when the patient gets there. Their fasting glucose should be less than 120. That's what we want to see. Then what we're going to do is we're going to administer 50 grams of oral glucose and wait about 45 minutes. Okay, so we're giving them, usually they're those little diabetic like orange drinks that you see. So we're going to give them glucose. After about 45 minutes, we're going to check. If the glucose is less than 120, so if their glucose is down, that means their system is, even though you've given it, it's still starving for glucose. And so you've already answered the question if glucose metabolism is happening. So at that point, you can go ahead and give them 15 millicuries of FDG. Now, again, this millicurie may vary on your camera and your protocol, but it's going to be around 15 millicuries of FDG. If the glucose is not less than 120, if it's still up, then what you're going to do is you're going to give insulin every 10 minutes until we get that glucose back down to less than 120. That insulin, when we do that, when we give them the sugar, and then we get it up, and then we give them insulin, you're creating, basically, that's where you're creating the metabolism for sugar. The body or the cardiac tissue is going to kind of switch and just want to look for that sugar, and crave that sugar. And then we're going to give again, 15 millicuries once we have them below 120. Now, I had a patient, or I mean a student once when I explained that to him. Essentially, what you're doing is you're trying to get the heart muscle to want the sugar, take it away now that you've got that engine of glucose metabolism turned on, and then give them the FDG so it guarantees the FDG gets soaked up really well. Okay. And yeah, I had a student once that he got on here and he's like, so what you're telling me, and maybe I shouldn't even say this or whatever, but he's like, so what you're telling me is this is like a crack dealer. And I was like, what do you mean the crack dealer? And he's like, yeah, it's like a crack dealer, you know, the first one's free and then after that you have to pay for it. And I was like, okay, I guess I can see what you're saying. But anyway, I thought that was kind of funny. So I've always remembered that. But yeah, essentially giving that a lot of sugar so it likes it, taking it away so it craves it. Okay. Once you do that, you're going to acquire a 10-minute PET acquisition 1 to 2 hours later. Again, heart tissue can take a little longer to uptake FDG. We increase that by doing this protocol. However, the other reason we go 1 to 2 hours later is remember the whole issue that we're after here is an area that has really low blood flow. So normally when you give FDG oncology and you wait your 45 minutes or an hour, right? You're waiting that long and allowing the uptake to happen. Usually it happens actually fairly quickly because the cancer cells are like, sweet glucose, we love it. We got plenty of blood flow, let's go. Again, here the myocardium is low blood flow, and so you're going to need to give it a little more time to get in there. Okay, so usually we at our facility we go 2 hours minimum, and often we go like 2.5 hours, depending on, you know, especially if the person has a really low ejection fraction on their rest stress, and so they have less circulation. We might go even like 3 hours out, depending on the patient. Now with this, you're going to acquire a 10-minute image over the heart. Many facilities will also have you acquire a whole body image. The main purpose of acquiring a whole body image is, one, you're really not going to give much more dose because you're just, you know, it's already in there, it's there. But one of the reasons we do it is because we want to see brain and we want to see bladder. We want to see normal uptake of FDG. The reason being is that, again, by nature, we're trying to answer, is there viable tissue? It may well be that there's no viable tissue. And so if we pull up our pictures and we don't see anything, then we could assume, okay, the cardiac tissue is dead. But how can we then say, well, did my FDG, was it good? Was it a good dose? Did it work correctly? Did it metabolize? So one of the ways to prove that, obviously, is to be able to see bladder and brain, because that's normal FDG uptake. Okay. So at our facility, we'll do one right over the heart so we can get specific into the heart, but we also do a whole body scan just like you would in oncology, eyes to thighs, right? The other thing we do at our facility is that when we do that, our oncology department and the radiologists up there, we actually have them do an overread. So we'll send that, even though it's just part of our charge and our study, we'll still send that to the radiologist just to do a whole body overread. And we have actually found issues more than once where patients have had some possible cancer stuff going on that they didn't actually know about, but we saw it on the whole body. So kind of a double benefit for the patient. Okay, so let's look at some images.
I have a question real quick on that.
Yeah, go for it.
So when it says that the baseline glucose should be 120, was that include the diabetic patients? Because usually they're higher.
Yeah, I mean, that's a good question. When we typically do these, at our facility, we have our PA is kind of overseeing it. In fact, we don't give insulin. The PA does all of that. The only thing we give is the FDG dose. So you're right. That can be something that varies with the diabetic patient. And my advice to you would be to follow either a physician or a PA on those particulars. You should have somebody there that would be overseeing this. And generally, again, you're not going to be the one giving insulin, so someone should be around that does that. But you're right. Diabetic patients can be an issue with this test. And I've had some diabetic patients, depending on where their glucose is, that we just can't perform the test because it'll just get in the way. But yeah, great question. Did that help?
Yeah.
Thank you. Yeah, guys, remember, interrupt me at any time. Okay, so let's look at some pictures. So on here, we've got on the top, we've got our stress. In the middle, we've got our rest, and then we have our FDG, our viability, on the bottom. And so this is really cool. This is a positive test. You can see that we had kind of this inferior lateral defect here that kind of goes throughout towards the base. And then you come down on these pictures and you can see that we have FDG uptake in that same area, right? So this is pretty cool. This shows us that that tissue was not dead. Rather, that tissue is likely just hibernating myocardium. And if they go in, they can probably get blood flow back to this area. Possibly like with a bypass, maybe stent. Bypass is probably more likely on something that's been hibernating. But we can reperfuse this. And you can see it. You can see it really well down here too. Some areas that really uptook where they were kind of just on this slice 83 here. You can see that this septal wall, it looks just like a shortened septal wall, but you can come down here and see that it was probably just missing in general out there. You had a little more here. You can see right there. There can be areas on here where some of the normal tissue will also uptake the FDG. And that's okay, because as long as the area that we're looking for has also shown up, we've proved our point, even if areas that are perfused also grab a little FDG. That can happen as well. But either way, even if all of the good tissue grabbed the FDG as well, we'd still be able to see that our area that had a fixed defect either filled in or didn't, okay? Here's another one. And that's, you can kind of see that what I just said on these images a little more. So you'll notice here on these slices that you have quite a bit of fill in on this kind of anterior towards lateral. And you'll see on the slices that you did have some perfusion anterior, but you didn't have as much coming lateral. And definitely inferior, looks like it filled in a little more. It does look like there's a spot kind of on the very lateral side that possibly could be kind of more on the MI. But it's a very small area, if any, but most of this area that we were concerned about has definitely perfused in, especially up here where we had some blood flow, but it was pretty reduced. That means, you know, FDG went into that area really well, which means definitely worth perfusing and doing something with. You can see some of that same stuff down here on these other images as well. You can see it on this horizontal long axis right here. You had pretty good on that septal wall, and nothing down here on the septal wall. So none of the good tissue took in the FDG, but all this area that was under perfused really soaked in the FDG. So yeah, that's viability. Any questions? Like I mentioned, if you want to kind of do any studying on your own, there's also we do a similar protocol for what's called sarcoidosis, which is cardiac inflammation. When your cardiac tissue gets inflamed from different things, including what's called a sarcoid, you can get tissue that's has a lot of pressure and inflammation on it, and it also gets low in blood flow. And we use a very similar protocol to this to see if we can determine if that tissue is low blood flow because of inflammation, or if it's low blood flow because it's dead. So you can look at that as well. Again, that one's not on your boards yet. All right, we're on our last thing. And hopefully we can get you out of here pretty quick. This one won't be as long. And if you guys need to leave, I totally understand. So this is cardiac amyloid. So amyloids, they on the test, even on your boards, ARRT calls this a PYP scan. PYP stands for pyrophosphate, which is one of the nuclides that's used for this test. There are other ones used as well. They're both technecium based, but the more appropriate name is cardiac amyloid, not just PYP scan. And with different nuclides being used for this test, you'll probably see that change to where they'll call this an amyloid and not a PYP, even on the ARRT. Again, right now, ARRT just calls this a PYP scan. So anyway, but cardiac amyloidosis, it's a rare disease, and it's characterized by deposits of amyloid proteins in the cardiac tissue. So these amyloids are basically misfolded proteins. They honestly don't really know why these happen or where they come from, but it's these long branched chains of proteins that essentially fold wrong. And because they fold wrong, they kind of lose functionality, and they can form in other areas besides cardiac tissue, but cardiac tissue is one of the areas that they form. And essentially, they just get in the way of normal function of the tissue. This is probably inaccurate to say, but my mind for some reason kind of thinks of cancer in a similar way. Like cancer tissues proliferate, and they proliferate in where places that they shouldn't, and cause functionality problems. Obviously, cancer has much more problem in terms of what it can do to somebody and all of that. But in a similar way, this is tissues that just go where they're not supposed to be and fold wrong or cause problems with that tissue being able to do its job. What this looks like in most hearts is heart failure. It's a thickening of the tissue, and it makes it so your heart, doesn't have as good of an EF, and it's not functioning as well. In fact, a lot of people who will come in, and the doctors will be trying to answer their question of why is this heart tissue thickened, and why is this patient in heart failure? Could it be because of these amyloid proteins? Okay, and so that's what we're trying to find. So essentially, with this, you're going to bring your patient in, or actually, before I do that, let me tell you kind of. Let's go back to the nuclides used here. I mentioned pyrophosphate, which is PYP. And then the other one that's used really often, in fact, our facility has gone to just use it's hydroxynate. It's HDP, so very similar to MDP that you use for your bone scans. And the prevailing theory, again, this is kind of a theory. Amyloid is fairly new, and they're still trying to figure it out. But when they've gone and done really close imaging of these tissues, when they've biopsied them and taken them out, is that they have a high amount of microcalcification in them. So if you think about the way that your bone scan works, right? It's a phosphate analog, and so your MDP, when you do a bone scan, it's attracted to the calcium and the phosphate in bone, right? So this essentially works exactly like that. It's attracted to the amyloid because of the microcalcification is what they think, and that phosphate will go and attach. And so that's kind of they just call that the prevailing theory, but they think that's how it works. In terms of how you do this scan, there's not any patient prep required. There's nothing, they don't have to fast, they don't have to do anything. You're going to inject the patient with 10 to 20 millicuries of either the PYP or the HDP. Not all facilities will acquire an immediate image, and when we get to our images, I'll show you why you should. But you can acquire an immediate image, usually like a 5-minute image. It's just a static over the anterior portion of the heart. This is going to be just your normal collimators because these are technetium-based products. And this is just H mode. This isn't done in cardiac, in L mode or anything like that. So just normal mode, just an anterior image over the heart. And then you're going to let the patient circulate for 3 hours. So this is very similar to doing a bone scan, right? Because it's a very similar way that it all works. So just like a bone scan, you're doing a whole body, you bring them back 3 hours later and scan them. Same idea here, just time for that to uptake with that potassium analog. Okay, so when they come back at 3 hours, we're going to acquire a 750 count anterior LAO and lateral over the heart. Again, just L mode, so we're just doing statics. And then a lot of places will also do a SPECT CT image over the heart, just in H mode, just a normal SPECT, doesn't need to be a cardiac type SPECT with the LAHR. So again, not everybody does a SPECT, but I'll show you with some imaging why it's a really good idea to do a SPECT when you do these as well. So let's look at some images and what we get. So what you can see here. So
I got a quick question for you.
Yeah, go ahead.
What's the 5-minute portion for? Because at my site, we don't do a 5-minute. We just inject and have them come back in 2 to 3 hours, and then we do the LAO, the A and the LAO and laterals, and then a SPECT.
Yeah. So and that's a very normal protocol. I'll show you on my second picture here the reason to possibly do it. In fact, we can just go. Let's see. Let me show you this image really quick Curtis, and then on my next image, I'll show you exactly why we do it. So this first image is probably like what you do, Curtis, on your protocol. So this was done without doing that initial image. This is just, we injected, waited 3 hours. Our protocol used to be without that 5-minute image. So let me here and kind of show you on this, and then on the next picture, I'll show you one with the 5-minute image and show you why it's an advantage, okay? All right, so when you get your images up, you just got your planar images here, and essentially what you do to analyze the data you have here is you're going to do an ROI over the heart, and then you'll typically do a contralateral ROI over kind of the lung rib area, okay? Technically, what you're using as background here is bone, is rib, and you're going to have uptake in the ribs just like you would on a bone scan, okay? So that's why we use it as the background. Again, both happening because of the calcification. So you're going to make these two, and you're going to create a ratio of how much activity is there. Most of what you'll do will be off this anterior image. These other images are mostly to kind of locate the heart and see where it is. And I'll be honest with you, this isn't the best scan in the world. You can see that it's still pretty pooly, pretty blood pooly. But we'll get into some other images that are better as well. So the way that this works, or the way that it's rated, if you go down there, they do it in grades. So when they get this, when you do your percentages and you get a ratio or a number, on this one it had a 0.84. The way that it works is at grade 0, or excuse, that's not what I want to show you. I want to show you this. So the ratio down here, if it's less than 1, it means it's not suggestive. Okay, so in this case, it said that the ratio between these is less than 1. In other words, the heart wasn't greater than background. They were pretty equivocal or equal. And so it's scored it as a 1, which is not suggestive. If we have a ratio of 1 to 1.5, it's equivocal, which essentially means you're seeing some equal distribution there. So again, the doctors have to read these as kind of a likely versus not likely. It kind of reminds me a little bit of the lung scan. When they read a lung scan, they say it similarly. And then anything greater than 1.5 is strongly suggestive that the amyloid is there. Okay, so that's one kind of data set that they use. And then they'll grade this. Here's your 0 to 3 grade. They'll give it a grade as well based on uptake. And they say like grade 0 is no uptake and normal bone uptake. So they'll look at the bone, see if it's uptake, look at the heart, no uptake. Grade 1 is uptake less than rib uptake. Grade 2 is uptake equal to rib uptake. And then grade 3 is uptake greater than rib uptake with mild or absent rib uptake. So if the ribs are lower and the heart is higher. And so that's how they kind of grade this as to the likelihood of the amyloid being there. And then I have a CT scan over here, and you can see right here, this is kind of where the heart would be. And what you can do is you can do some ratios over here as well. So in this case, we did a rib, and then we did where the cardiac tissue would be. And again, those comparisons are low in number. So that's kind of the idea. Now let's get more to what Curtis was talking about and look at images that this is kind of normal, right? This looks like no cardiac amyloidosis. We have a really low number. Let's get into something and look at it a little differently here. This will help answer the question. Okay, so this is, Curtis, this is where we did that 5-minute image, okay? You can see the 5-minute image. What will happen is you're gonna get a lot of uptake in the cardiac tissue immediately. It will highlight as blood flow just generally goes through. And the 3 hours, a lot of times if you don't have amyloid, that'll wash out. But if you do have amyloid, it will stay in, okay? And so the purpose really of doing that initial image right after you inject is because you can have times where you bring the patient back. And this one is fairly obvious. When we did this is our 3-hour image, like I could still see the heart on this one and able to put my ROI around it. But there's plenty of these that you come back and it's super hard to tell where the heart was. And that might just be because there's no amyloidosis and you can't tell, but you still need to be able to put your ROI in a place that matches where the heart actually is. So what this does is it helps us to see where the heart is so that if later they come back and most of that's washed out and we don't know where to stick our ROI, we can put our ROI in a better place and just guarantee that our numbers are better and more accurate. Again, you're not giving the patient any more dose. You're not doing much other than just helping yourself as a technologist to be able to know exactly where the heart is and where you're at. Now, when you do this, typically at our facility, we'll try to like pay attention, I'll put a piece of tape or something so that I know on the patient, I'll pay attention on the patient to where I'm lining them up and try to line them up in the same place. But if I have them like this, and I can look at, you can see things like, for example, kidneys, you can kind of see kind of like top of the sternum and areas to line these up correctly. But if I know what the heart looks like here, then I know what kind of ROI and where I need to place that ROI over there. So that's why we do it, Curtis. It's not, you don't have to do it, but I've seen multiple facilities doing it that way for that purpose. Again, you take up your camera time for a quick 5 minute, and that could be problematic depending on how busy you are. But that's the purpose of it, is to get an accurate ROI at the point where you bring them back. Okay.
This is more in just the PET than it is in just the regular gamma cameras, right?
So this is all done on a regular gamma camera. This is a tech-based product. So PYP cardiac amyloid is not PET. This is all done on SPECT.
Okay, I was wondering because your picture to the right looks like it might be a PET CT overload.
Yeah. No, it's just a really good looking SPECT. But yeah, this is a SPECT, and I wanted to point out that too. So in our previous image, there wasn't a whole lot there, but you can see that this SPECT is really helping us to see the cardiac tissue. So what you're seeing here, right here, this is lateral wall, okay, apex, and then the septum would come right through here. The septum is actually not there, so there's not cardiac amyloid in the septum. And then what you're seeing here is actually right ventricle. Okay, so your left ventricle would be right here in your little horseshoe shape, and then this is right ventricle. And so this is a good way to look over and kind of verify again that you can see, and your doctors can do measurements over here if they want. But it's really nice to be able to really see. And again, this is only one slice of this SPECT. You could go through it back and forth and get a good look. But this is a lot prettier and just helps doctors as opposed to just this over here. But then the third one I want to show you is kind of, let's see, do I have three or actually, yeah. So there's another one. So I'll just let you look at that. Not much I'll say about this other than look at our number of 1.7. I think our last one, what was it? Yeah, 1.9. So again, these are all in that strongly suggestive category. That one's 1.7. So again, strongly suggestive. You can see this one. I mean, this one almost looks like a perfusion scan with a couple of defects or something, But again, those are just where PYP is gathered, right? It's not telling you anything about how the heart's perfusing. It's just saying there's that PYP or that amyloid. I shouldn't say PYP now. I told you not to, and now I'm doing it. But that cardiac amyloidosis tissue in there. And then this one's really interesting. So if you look at this one, we got a 1.6, right? So that's going to be strongly suggestive. And this is my argument for why a SPECT is really good. If your facility is not doing it, it's a good idea to do it for this one right here. But so here's our initial image, right? And we did an ROI over the heart, like, okay, there's the heart, sweet, we can see it. And then our image when we came back looked like this. So again, you can kind of see where the heart is, but it helped us line it up. We got our 1.6. But it looks from the picture like, okay, there's probably enough heart there, enough uptake that I think this probably has some amyloidosis. It looks like it from just looking at this single image. And then, of course, the number said that it's suggestive, 1.6. So off of that data, you would be like, yeah, it looks like this person has it. But if you go over to the SPECT, this becomes really interesting. What you see here is you see this activity kind of right through the middle here. And what you're actually seeing is you see no activity here in like this nice horseshoe shape, right? Well, that's exactly where the heart is. This activity or this lack of activity, you can see a nice horseshoe shape of the heart. And what you're seeing here is actually ventricle. So what this is picking up on this patient is they still have a lot of the PYP or the HDP, whatever was used here, in the bloodstream. Some of that, as you can see in the static image, is definitely taken up in the bone, right? You can see, you start trying to do a bone scan there. But what this spec shows is that even though over our ROI in the area of the heart, there is activity, that activity is blood pool activity. It is not, in fact, in the cardiac tissue. You can actually see, here's the left ventricle, and this spot up here is actually the right ventricle, because your cardiac tissue, your left ventricle is here, and your right ventricle's here. Okay, so huge advantage in looking at SPECT. The doctors saw this and said, hey, they actually called this negative. They did not call it positive. And again, by just the static image, you will call it positive, but the advantage of doing a SPECT, you can see right here. And I drive that home because our facility, when they first started doing these, a long time ago, they were just doing the static images and not doing a SPECT. And over time, as they read literature and saw things like this, now they do SPECT. So if your facility isn't doing SPECT, show them this. It's a good idea to do a SPECT on amyloid scan. So we're done. Any questions?
So anything 1.3 or greater is abnormal for that PYP, is that correct?
Yeah, 1.3 or greater is abnormal.
Okay. And you utilized a spec CT, is that correct?
Yes. Yep.
Okay, 10-4. Thank you
Yep.
very much.
Yeah, no problem. Of course. Thanks for the questions. Yep, this is all done SPECT. I don't know of a nuclide that is on PET. If there is one, if they're developing one, at which they are coming up with some nuclides for bone scans, so maybe it'll work for amyloid too for PET. So yeah, maybe in the future it will just go to PET, but who knows? So, any other questions?
They
Okay.
also call that stiff heart syndrome too, no?
Say that again.
Don't they also refer to the amyloid buildup in the heart as stiff heart syndrome?
Yeah, I've heard it called that. No, I don't hear it very often, but you're right. And again, it's why it looks like heart failure, because you get this thickening and stiffening of the cardiac tissue because of those misfolded proteins. So yeah, I've heard it called that before.
And I know that it's not just in the heart that it can accumulate, but are there other exams that we would find ourselves locating this amyloid for, and as far as organs go?
Not that I'm aware. I know that there are other organs. Like I know you can get it in your lungs. I don't know. To be honest, I haven't studied other outside of cardiac. But I know that in terms of nuke med, there's not. I'm assuming that may be because there's some other modality that has a way of finding these better in other tissues. But my most honest answer is I don't know. But the other answer is I not that I'm aware of, or other modalities. Yeah. But yes, amyloid can be other places. Anybody else? Okay, I'm gonna stop my share and we'll end the class here. The only thing I would say at the very end is just again, try to get all your stuff in. You got a couple weeks left to get everything handed in and done. Please let me know if when you're turning in exam 2 test corrections, if there's the same problem, then I'll add another one and we'll figure that out. But yeah, just get the class finished up. We'll get your grades in, and then I will see you guys again on May 15th. I'll try to have your Canvas classes for summer up somewhere around the 1st of that week. So like, was it the 11th or 12th or 10th? Let me look. Yeah, so probably that weekend, which is like the Saturday is the 10th. So somewhere close to that. I'll try to have them up for you so you can start looking at things, and then we'll meet on the 15th. Okay. Thanks, you guys. I'm gonna end the class.
Just real quick,
Yeah,
I
go
just
ahead.
popped into the exam 2 test corrections. I'm getting the same thing as before.
Shoot. Okay. Well, I'll just add one
Okay.
then. I'll just add the other one,
Right.
and then
Okay.
we don't have to worry about it.
Cool.
Thank you.
Okay.
Thank you.
Yep.
Thank you.
See you guys.
Thank you.
Welcome.